to Tea with T Cells. This is Marta.
I am Shafka. Tea with T Cells. Today's Tea with T Cells fact is actually about tea and T cells for the first time. Ding, 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 ding. So, there was a study in 2013, and actually there's been quite a few studies, but I'm specifically talking about the study in 2013, that looked at a compound called ECCG, I'm going to struggle to say this name, epigallocatechin 3 gallate, ECCG, which is found in green tea. And there was a study in 2013, as I mentioned, which feeds this compound extracted from green tea, so ECCG, to mice. And then these mice were then given EAE, which is an experimental version of multiple sclerosis. And what they found was that mice that were fed ECCG had reduced multiple sclerosis compared to mice that were fed just normal food and water. And then these guys then went a bit further to try and understand exactly what is happening in these mice to reduce their multiple sclerosis-like symptoms. And what they found was that they were actually slightly modulating how their T cells, which population of T cells, get activated in these mice. So normally, in a healthy immune environment, you expect there to be some inflammatory T cells, but also some regulatory T cells. But in these autoimmune diseases, you get way too many inflammatory T cells and way too little regulatory T cells. But it seems in these mice that have been fed ECCG, you redress that balance. So you get more of these regulatory T cells and less of those inflammatory T cells, which is what reduces the effect of that disease, which I think is quite exciting.
Today, let me welcome our first guest, Dr. Stephen Emegbo.
Hi.
Hello, Stephen. It's been a while since we announced that we wanted to have you as a first guest, and we really love research you're doing, and it was a pleasure to invite you here today. So for those that don't know, Dr. Stephen is academic lecturer and researcher at Sheffield Hallam University. He is a sleep scientist.
Yes. Very excited to have you here, mainly because I have lots of sleep problems.
Yes. So partially we invited you because we both want to find out more about the research. However, I think that this conversation will be very useful for our colleagues at Hallam, but also other people.
I also think it's important to mention Stephen has a really interesting career journey, very different from maybe me and Marta. So we would like to know more about that as well in this podcast. So we'll explore both of these, sort of the research of sleep and then your journey in academia and everywhere else that you've been. So yeah, welcome, Stephen.
So, Stephen, you've spent over 25 years working across clinical, research and academic sides of sleep science. What first drew you into sleep physiology as a field?
It's one of those things which, I'll be honest with you, I didn't initially think I wanted to go into sleep. What happened was I studied an undergraduate degree in human physiology, and like all of my colleagues at that time, for some bizarre reason, we all went into retail management directly after graduating. I don't understand what happened. It was one of these things, kind of an aberrant phase, like a couple of years at sea sort of thing, where I don't quite understand why my thought processes wanted me to do that. Maybe it was just to start paying off my student loans and things, but I got a job working as a customer services manager. Within about 3-4 weeks, I was pretty sure I didn't like it. I realised that kind of work was great and I did enjoy it, but it wasn't where I wanted to be long term. So I quickly decided to leave. And one evening, when I was supposed to be managing the customer services area, I grabbed an Evening Standard newspaper, went down onto the shop floor, sat down with it and found some jobs. Applied for them that evening, and one of them was as a medical technical officer at University College London Hospitals, UCLH. I applied for the job, I got it straight away, working as a medical technical officer doing lung function tests, basically. And also involved quite tacitly in the sleep service that was being set up, or set up there on the Campbell Thompson ward. But within about 2 weeks of working at UCL, one of the consultants, Professor Stephen Emegbo, bumped into me in a corner in a corridor and just came up to me and said, "Stephen, you're a new graduate and everything else. Would you like to be involved in the clinical trial?" I was like, "Okay." And he said it was a study looking at gastroesophageal reflux in obstructive sleep apnea. And I kind of thought, can I do this? But in for a penny. So I went along to the Robbins Institute, and I think within about 25-30 minutes, I knew that sleep was the area for me. Not because of the research that was being done, it was just the fact that there were so many easy and fairly obvious gaps in the knowledge base. It was really exploratory work that they were doing, and I just was literally bought into it. And the colleague who was actually running that trial was a chap called Professor Tudor Toma, and I just remember him and I chatting over coffee about a day later, and he was just telling me all the areas that he was interested in, and I was like, I want some of that. I really want to be involved in everything you were saying. And I just was bought on that moment in time. I stayed at the Robbins Institute. I kind of shared my work, did some work at the Robbins, did some work in other places, learnt about sleep physiology, concentrated in that discipline in sleep, went on a few courses, became like a clinically proficient in sleep. And then after about 2 years, having done my master's as well at the same time in sports physiology, because I was still interested in physiology as a pure discipline, so I did sports physiology at Brunel. But after about 2 and a bit years of working at UCL, I left and went and took up a research role at the University of Surrey, working with another absolute legend in my lifetime, Professor Ian Hindmarch, who was an absolutely wonderful person. He had this phase where he'd go, "Lovely biscuits." It would just make you giggle. But he was such a warm and supportive person, but an eminent person. Whenever you mentioned his name in the area of psychopharmacology, everybody knew who he was. But to see him being quite open and friendly with you was amazing. It was a really quite open and wonderful experience. Subsequently, I started my PhD there as well.
So you mentioned that you did a research role just after your master's. What's that role? Like, how did you get it? What kind of role is it?
It was, I had to do research for my master's, which it had to be tied into the job that I was doing at the time, which was working as a medical technical officer. But it also had to meet the requirements of the postgraduate degree in sports science. So what I did was I looked at a research project looking at breathe right nasal strips and other things that athletes wear across their noses.
Yeah. I've seen those.
Yeah. For 2 reasons, actually. One was that I was always interested in the ability to improve physiological performance in exercise. And one of the question marks we had was about these breathe right nasal strips, because lots of athletes, especially the distance runners, were using them. And at the time I was an athlete as well. I was a 400-meter runner. And I just thought, well, would it help? But I was kind of fairly sure that if 400-meter running is an anaerobic process, you are not really taking on a lot of oxygen other than towards the end. You are still breathing, of course, all the way around, but your muscles at tissue level, it's going to be largely anaerobic processes that are going to energize you through the run. So are these strips beneficial? Because I'd seen a lot of people still use them in those events. So I kind of questioned it whether it was helpful, but the literature wasn't clear on that. But the one thing that it was very unclear about, and I really needed an answer, was whether these strips triggered asthma in individuals, because there was a concern that dilating the nasal passages, nares and nares, means that you actually reduce the capacity of the nose to do what it's there to do, which is to heat and humidify the inspired air. So there was a concern that by reducing that heat and humidified air, you could trigger asthma.
So would that trigger it in people who are already asthmatic?
Yeah. And exercise-induced asthma is very common.
Yeah.
Lots of athletes have it and don't realise it because they're aerobically fit. So they only find out when a problem really occurs and they have a massive event, and then you end up losing tooth to hospital and things.
Yeah.
So I wanted to check to make sure that it was safe. So we set up a study looking at exercise-induced asthma, but looking at these breathe out nasal strips as an adjunctive role in if it could trigger and stimulate an asthmatic event. Rest assured, the conclusion was they don't. Nobody's at greater risk.
But how long was that project? Because you ran it straight after your master's, right? And how long was that project for?
It was about a year we did it over.
Okay. That's really good to know that you can have such a big impact straight out of your master's with some relatively short research, which is quite impactful.
Yeah.
The knowledge is quite useful.
Well, it was useful information. It was great information. The dilemma was it couldn't really use it in the way that I wanted, partly due to the fact that the manufacturer of these strips, 3M, had made it very clear when we kind of approached them about it that they didn't want to do any kind of additional research on this. They were quite comfortable with the information, but we proceeded anyway because they had already been licensed and were available in the public domain. So we wanted to answer that question. Like I say, I was reassured by the fact that they didn't cause any additional risk to anybody. What we also found out is that I actually had asthma at that point because I did the exercise test, and part of the test was to see if there was any reversibility associated with the exercise. So we would look at somebody's lung function, and then you'd give them a bronchodilator just to be sure that they were in the right group effectively. And it was signed off by Heminder Maka, who's one of the consultants there, a legend as well, a lovely chap. But long story short is that I had the bronchodilator, my lung volume increased by over 50%. I think it's 54%. So I had asthma. It was like, Stephen, you're in the wrong group right now.
So you just found that out there and then
out
that you had asthma?
Trial. Yeah, in my own trial that I was doing, that I had to be I had to move sideways so my data went from one group into the other, so that I was asthmatic. But it was one of those moments where I kind of giggled, but it was a nice trial that I was able to design and construct, and again, it was due to the fact I was working in that environment that I was able to pull it together.
I already have so many questions just to this particular study, but we can talk about it later on. However, you said later on you went into PhD. Was it difficult for you to get to PhDs, or was it straightforward that you just
The
needed?
answer is yes, because I made the fundamental error during my PhD. Two errors, actually, I could say. One was I did it part-time. And anybody who already has a job who does a PhD, anybody who's doing a PhD right now will know that it's a busy job.
It is.
I think you're underselling that.
It's very busy. Okay. If you can imagine then not committing all of your time to your PhD and committing supposedly, and I'm doing this in speech marks, 36 hours a week to your job and then try and do your PhD on the back of that, you can appreciate that it's really difficult. But I was actually a research team leader involved in clinical trials, and when trials were on, I would be residential. I would actually have to stay in the HPRU and to oversee projects. And I also lived about 50 miles away from the University of Surrey, so popping home and back again wasn't easy. So it meant that I would get like a bag of stuff. I would stay at the centre up from Monday through to Saturday morning, go home, have a weekend, party, see friends and things, and then Monday morning repeat the cycle for 6, 7, 8 weeks at a go. And I was doing like 95-hour weeks and things. Because the problem was that if there was a problem with the study, or if tests need to be done in the evening or whatever, and somebody was sick, because I was there, it would default to me. So trying to do your PhD in that environment is, not the best. I also had Professor Heinmont was my initial supervisor, my PhD, but due to poor health on his part, which was really sad, he couldn't continue as my supervisor. So I had to then change supervisors. Unfortunately, the supervisor I had, Professor Dirk-Jan Dijk, didn't agree with some of the research projects I wanted to do or what I was currently doing at that time. So subsequently, I think I ended up with 15 different iterations of my PhD based around
15.
Yeah.
In terms of writing it, or in terms of your ideas?
In terms of ideas, So I had to.
So quite early on.
Yeah. So no, I'd already done about 3 years.
That's not.
With Professor Heinrich, and then had to start again.
Wow.
So I was very much like arms crossed, staring at the ceiling, going, "Why is this happening? Why is this happening?" But eventually, after much umming and ahhing and toing and froing, we settled on an idea where we were looking at a data set from a particular clinical trial that had actually been stopped because of some safety issues around the drug. I would argue that they weren't really big issues, but the manufacturer felt that they didn't want to take the risk with a study drug. And this particular study drug, the way that the study had been designed, meant that we had lots of healthy individuals, over 250 odd patient data sets, in healthy individuals at multiple times over like a 2-week period, which is like unheard of to have that much data. And we all had the way that the study had been randomized, we had a lot of data in the baseline condition. So we had a lot of normative data to use, which is like, wow. And these are people who had no other comorbidities, so no secondary sleep disorders. It was a clean, clear population. So
that's rare in science.
Yeah, it is very, very rare. I know, again, speech marks what's normal in this context, but it was as close as at the time as we could get. So I was absolutely delighted to use the data. The manufacturer very graciously allowed us to use the data respectively, so I was then able, and I collected the data as well because I've been involved in the trials doing those 95 hours stuff. So it's like I was intimately involved in this project. So I was able to take that data, analyze that data, and look at the age and gender differences or changes in sleep across the adult life course, which in essence had been done by some other people, but in bits. This was the first study, I think anyway, that had actually pulled all the arms together and was able to kind of demonstrate what the nature of the change in sleep propensity is over the adult life course.
So what do you mean by sleep propensity?
The sleep parameters, like the sleep elements. So the simple fact is to kind of give you a very quick sojourn through my PhD thesis in the briefest way as possible. When we age, our physiological dimensions change. Okay, one of the clearest things is that like there's tons of work by a lady called Wadine Spiriduso, which shows that when you get to about 23 years of age, that's your peak, and after that you start to physiologically decline thereafter. Well, sleep manifests in exactly the same way, but not as brutally as that. What we normally see is that by the time you get to your 50th year of life, you know, sixth decade of life, starting your sixth decade of life, the amount of slow wave sleep, which is the homeostatic marker, the thing that really gives you good quality sleep, is slow wave sleep. And what we were able to show, and what my supervisor, Dr. Ken Dyke, had shown previously, is that by when you get to 50 years of age, you have about half the amount of slow wave sleep as you would ordinarily have when you were 20. So there's a massive reduction across the adult life course. But what's not often talked about in this model, this is what my study was hoping to show and did show, is that those changes are also manifest both in males and females at a similar degree. However, the problem with females is that the rate of slow wave sleep decline across the life course and across the nights is greater. So what that basically means is that the slope, the gradient, is much steeper in women as their slow wave sleep resolution across the night compared to men. And that basically means that women's sleep is much shorter of a night time.
Oh, wow.
I've just thought of a question based on that. You may not have looked at this at all, but is that also the case if the women go through pregnancy or not?
Well, actually, the theory that we work towards as being a factor in this is related to pregnancy, in so much as from an evolutionary endpoint, okay, the process of bearing a child means that when the child is born, somebody has to feed it at night time or in the early hours. And normally the offset period of a child can vary from parent to parent. So it can sometimes be that your child plays the game nicely and goes to bed at a reasonable clock, wakes up 4, 5, 6 in the morning kind of thing, and you get a nice chunk of sleep. Other parents, it doesn't work like that. So from an evolutionary endpoint, a mother having to respond to their child at night time doesn't want to have tons of slow wave sleep still in their system, which will make them groggy, less safe, less able to function if their slow wave sleep is still being expressed. And physiologically, just as an additional point to make, we all, as both males and females, always try to resolve as much slow wave sleep at the beginning of the night more than at the end of the night. So by the time you get to about 3, 4, 5 in the morning, you should have minimal amounts anyway. It shouldn't really be around. So it should, for most people, be reasonably okay. If your child wakes up at 3, 4, 5 in the morning, you should be able to function in speech marks. Doesn't always. Every night that your child's waking up, it becomes harder to manage, of course, but the chronic effect of it. But the theory that we worked on is that the reason why the gradients is greater is because women want to kind of get through their slow wave sleep more efficiently, so that when the child does wake up and then they have a responsibility to feed, they're not groggy. And from an evolutionary endpoint perspective, like selective pressures and so forth, if you're waking up groggy, and when we lived, like Homo erectus living in the wild, if you woke up groggy, you would stumble off a cliff, or you would stumble into the woolly mammoth's den and get trampled and things like that. So it wouldn't, from a safety perspective, it was an evolutionary importance to conserve the genes where the slow wave sleep was resolved more quickly so that you would wake up less groggy. So that was the theory that I postulated in my thesis. I don't think it's been challenged to date. Who knows? But yeah, it's a theory as to why it would be, because there's no other reason why slow wave sleep resolution should be different between men and women. And one other thing is that it's not a trait difference as well, because there are women who have a similar profile to men in terms of they have a longer period to resolve their slow wave sleep. Other women have a shorter, and men vice versa as well. So, but the interesting thing that we found from my work is that in my population of patients, just with normal healthy physiology in individuals, that their amount of slow wave sleep, that is total sleep, that is lost on a year by year basis. So 1.2 minutes in men, 1.5 in women. Okay, so over like a life course, that means you could quite easily lose 2 to 2.5 hours sleep.
So was that 1.5 you said per year? Per year. Yeah. Okay.
Yeah. So women could lose about 2 to 2.5 hours sleep. So they were sleeping for 8 hours. By the time they get to 50, 60, they could have 6 hours and still be physiologically in the domain of being normal. However, most people would manifest a large loss of sleep of that significance, like a quarter of their sleep effectively going, as being a problem. And thus would go to their GP saying, I'm not getting sufficient amounts of sleep. And there lies the fundamental problem that, no offence to GPs here, but they often would prescribe something like an antidepressant medication or a hypnotic, not realising that this is just the normal atrophy of sleep, and thus it won't be improved much above that. On a night-by-night basis, yes, you could take a hypnotic or a sedative to kind of help you sleep, but it won't push you back to having 8 hours sleep of a night time. The only thing that does is exercise, but that's another story.
Well, so I think for some of our audience, we would need to also explain what happens during the sleep, because we are talking about REM, non-rapid eye movement sleep. And I think some people, including probably us, would need to refresh this knowledge. However, following on what you have just said, one question that comes to my mind is, okay, we are losing the sleep as we age. However, does it follow this adaptation? Because you know that teenagers obviously will need more sleep as we are growing up and so on. But do you think from your point of view that at the age of 60, 70, 80, we just don't need that much sleep and hence that's why we lose it?
Oh, this is where I lose all of my friends in the sleep fraternity. Right, it's a difficult one to answer, because what we often would say from a clinical perspective around sleep is that if you go to bed and you wake up the following morning feeling refreshed and able to function, you invariably don't have a sleep problem. How much sleep you have is individual to each person, and there lies the difficulty in answering that question, because I've had patients who, for example, have had to sleep for 13 hours a night. And literally, if you made it 12 hours, try to truncate their sleep so they could fit more into the normal dimensions of life in the UK, let's just say, holding down a job, for example, they couldn't do it. And literally, they were unable to function. 13 hours, fine, 12 hours, a problem. Vice versa, I've had patients who, this is objectively was proven, a patient who only had 2 hours sleep a night. And I still, to this day, don't quite understand. We did the full PSG on him. He was an insomniac. Just to kind of give you context of this guy, he'd always been an insomniac, per his testimony from his parents and himself. He was very cognitively switched on. It was just one of these creative types. His brain kept on going, and he would do he was involved in a lot of things. So much so that when he couldn't sleep at night time, rather than sitting there staring at the ceiling, he actually set up an online jewellery business with America. So it was online, and he was training with America because he knew he wasn't going to sleep. They were going to be awake, so just do it. So we did a sleep study on him. I was adamant that we'll put him in our lovely sleep labs we had in the university, which were like sound attenuated, light controlled rooms, temperature controlled. He would fall asleep. I was like adamant. I was willing to put like a tenner on this. He'd end up 8 hours later. I was positive of this. But no, he got into the room. We wired him up, climbed into the room, switched him on, switched on the recording, and his brain was awake. And I saw his eyes were open. So I actually went in and said to him, close your eyes, please, and try and sleep. So he did. He literally, hands onto his head, pillow pulled up and everything else, got nice and comfortable. And I saw his heart rate relax and drop and everything else. So he did everything we asked of him, but his brain was just awake. and it stayed awake until about 1 o'clock in the morning, and then bang, he just fell asleep. And 1 hour and 47 minutes later, bang, he was awake again. And I still to this day, I don't want to use pejorative terms like odd or freak, but I don't understand that, because he woke up and we did psychometric tests to him on the next day and sleep latency tests throughout the next day, and he passed them all. So he didn't need any more from our objective assessments of anything more than 1 hour and 47 minutes of consolidated sleep per night.
To be honest, this sounds like a dream, because if you can sleep less, still be productive and do more things in your life, that sounds really cool. However, I'm sure that it comes with many side effects, because sleep is very important. But before we go to the importance of sleep, shall we just explain briefly what happens actually during the night? Why we're talking about the slow wave sleep and other types of sleep, because you've mentioned it before. Why is this important? And when we fall asleep, what are the cycles?
Well, let's first start with where everybody should be right now, which is wake. Okay, right now, our brains are fully receptive and awake and alert and taking in information. So we're highly vigilant. What sleep is the loss of vigilance for all intents and purposes, where the brain has gone into almost like an idle mode. Okay, so right now, everybody's brains are awake and active, and we're receiving information. There's a lot of cortical activity going on in the brain. When we then get to a period in the evening, or if we're tired, maybe in mid-afternoon, where our bodies get settled and ready to fall asleep, our brains start to slow down. And I'm trying to keep this as simple as possible. There's a lot more going on.
Of course.
And the one thing that I would also say to people is that the term falling asleep is a term that I really dislike, because nobody falls asleep in speech marks. There is a whole synchronized process going on where arousal is reduced and sleep emotion is increased, and parts of the brain have to be in the right configuration to allow sleep to happen or occur. If they're not, then you have a problem. So you don't fall asleep. Your body ordains that this is the right time for you to fall asleep. Okay, so that's important to say. So just wanted to make sure that's known. But effectively, when you're awake, your brain is highly vigilant and taking information. As we get closer and closer to the end of the day, our bodies become more tired, and because the theory that we have is that prior wakefulness, the amount of wakefulness you have, builds up a sleep debt, a sleep drive, and effectively, or eventually, you get to a point in the day where sleep is so important, so significant, that we eventually, the processes kick in and allow us to sleep. Then when we fall asleep, our brains start to become into a kind of a quieter state, defined by electrophysiological signals, the activity of our brain. And if you think about the cells in your brain, this is an analogy that I often give to my students when I talk to A-level students and so forth, to try and keep it as simple as possible, sort of thing, is that if you think about a concert, okay, and say, let's say Beyonce's playing on the stage, okay, or about to come on, the bit before she comes on, before there's anybody, people are just talking and active and having a nice discussion about what's going on, what's going to happen. Oh my God, I can't wait to see Beyonce. And everybody's talking. And if you listen to the sound, there's a lot of noise, okay? Then gradually, that's wakefulness in this context. Then the opening act comes on, and some people go, oh, that's whoever is performing. They go, oh, wicked, I like that person. So some of them will pay attention to this. Other people go, oh, I've never heard this person before. I'm still carrying on. I'm going to go and get a drink and things like that. So there's still a bit of hum going on, but there's music in the background, so the people are focused to what's going on. That is light sleep, okay?
Right.
And then when Beyonce comes on, which is the purpose, so Beyonce in this context is a bit like slow wave sleep, the homeostatic drive, the thing we need to have. She comes on, the whole brain switches off. Everybody's now paying attention. Occasionally people go, hey, Beyonce. And that's when slow wave starts to come through. People cheering and buying in to the element. So that's the kind of sleep. Doesn't explain REM sleep. I haven't got that analogy in that, but effectively REM sleep. So just to say, so basically, light sleep is where the brain is just switching off very lightly. We see electrophysiological features of slowing down of the brain, but the brain is still quite active during that phase, and we see one or two features.
So we are conscious. We can't be conscious during this time.
It's the easiest stage to wake somebody up from. If you can imagine, there's light sleep, stage 1 and 2 sleep is what you'd call church sleep effectively, or one is learning church sleep. That's where you might catch yourself nodding off. Somebody goes, you were asleep, and you go, no, I wasn't. Sort of thing. Yeah, everybody else could see. You had all the physiological markers. Your eyes were closed, head lolled to the side, and your arms were dropped down.
Just a bit of a doze.
Yeah, a doze. Yeah, and that's light sleep. But when the brain starts to get into deeper sleep, you start to have features of the depth of sleep, spindles and K complexes. So electrophysiologically, you see these either rapid accelerations in the repolarization of the cells in the brain, that's a spindle, or a large slow burst of activity, which is a K complex. Okay, when you see those, the brain is further away from wakefulness. The vigilance has become further away from wakefulness, and at that point it becomes a little bit harder to wake somebody up, but not impossible. Okay, eventually after a while the brain completely switches off, and what you get is a synchronous EEG forming, where the brain cells are firing in a kind of rhythmic fashion, but a very slow fashion. Those are slow waves. And to give you some context around how the depth of sleep that somebody can have in slow wave sleep, we did a trial where we were experimentally disrupting people's sleep. And to contextualize this a little bit for you, we had sound speakers above the head position of the people, the participants involved, and they could produce up to 105 decibel sound pulse sound,
wow.
So 40 kilohertz pulse.
That's basically like concert level.
A plane taking off is about 120 to 140 decibels at 90 meters away. Pneumatic drill is 90 decibels as you drill. Okay, yeah. And this one particular chap, I remember, he went into slow wave sleep, and we played the sound to him, and we could incrementally increase it. So you start low and you work your way up. I think we started at 60 decibels with him, and he didn't even move, nothing, no response. So we turned it up and up and up and up. Eventually, very quickly, we got to 105 decibels, and he was just not there. We were not stimulating him in any way. So rather than the pulse tone, we played a continuous tone at 105 decibels. So this is like a fire alarm going off, and he didn't respond at all. So at this point, as a concerned physiologist, I was thinking, have we just lost our first volunteer? But no, I went in and did a sternal rub on him kind of thing, just to kind of, hello, sternal rub, and he woke up.
Wow.
I was like, okay.
I need to tell the story to my mom, because she slept through an earthquake. And I'm like, she must be in that stage.
Slow wave. The power of slow wave. It's bizarre that particular stage of sleep is so protective of the vigilant state that we're in.
Wow.
It will block out all sounds, not all sounds, because there's a contextual element to it as well, because I know for a fact that I've seen people who, for example, have woken up to the sound of their child in slow wave sleep. So if there's information context around it, then the other analogy that I remember being mentioned to me around this is that nobody ever wakes up to the sound of thunder at night time, but most people wake up to the sound of a car alarm. They're similar, you could, without measuring being exact, but they can be at similar intensities and different sound levels. The difference is the frequency, the intensity.
So you're suggesting that the brain is basically, it can pick out which information it needs. It's still aware when you're in that state of sleep. It's just aware to only very specific things.
Well, if there's an information, the information content. If you imagine a high-pitched squealing sound, that might be like somebody crying, somebody in distress. It could be somebody you love or care about. So your brain will go, I need to respond to that. Especially if you're a parent, for example. That's the kind of thing that can sometimes happen. But if you get a low frequency kind of rumbling noise, if we're in an earthquake, like you mentioned, and the building's about to fall, it may be too late. So your brain says, well, what can I do in this scenario?
Just avoid the pain.
Or actually, another theory that I remember being discussed around this is that the reason why is because that lower frequencies are more consistent or contiguous with the brainwave activity, the low, deep activities. So it actually kind of mirrors or masks itself against the background activity of the brain, so the brain doesn't respond to it as well. High pitch is quite discordant, even if the intensity is appropriate. Because it's quite discordant, it drags the brain into wakefulness. So it could be an information thing, it could be just purely the energy and the sound that's being heard, but again, there's lots of people who can do that research. It's not something that I could see much strength in, because all that you are doing is finding a way to wake somebody up which they may not need. And there's lots of evidence to suggest that things like brown noise could be beneficial for some people. So a deep
brown noise?
Yeah. So like a deep rumbling noise. Lots of people have that in the background to help them to sleep. Yeah. And again, it could be just because it's kind of contiguous with the background EEG activity that the brain is trying to achieve to get into deep sleep. So
wow.
there's lots of
I just need to mention that my husband will wake up every time I go to the toilet at night, but he didn't wake up when there was a bomb explosion in Cyprus, and everybody heard it very well. So I don't know how we can explain this. However,
you going to the toilet is louder than a bomb explosion.
Probably not. Okay. So this is a slow wave sleep. How quickly does it come? It comes straight away when we fall asleep, and how long would it last?
Okay, this is where it gets a little bit trickier to answer, because the slow wave sleep is, like I say, this is a homeostatic marker of sleep. It's the thing that we theorise that the body needs the most when we go to sleep. Lots of physiological processes occur, like hormone releases occur during slow wave sleep, suppression of other hormones. We dream during slow wave sleep as well. Dreaming sleep, REM sleep, where your eyes are moving. We know you dream in that stage. We also know that people dream in slow wave sleep too. So, and memory consolidation as well, probably the most important thing. So all the stuff everybody's hearing at home is listening to goes into short-term memory. If you remember any of this more than a day or three, it's probably passed into your long-term memory during slow wave sleep, after the night after you've listened to this. So it is a vital component of our sleep. At this point, I've completely forgotten the question.
So this was the slow wave sleep, and how long will it last approximately?
Okay, how long will it last? Okay, so effectively, when you first go to sleep, you go into tertiary sleep, like slight sleep, N2, non-REM stage 2, sleep 1 and 2 sleep, where your brain is idling along. Within about half an hour, most people should have entered into dreaming sleep. And what we then have is a very long period of dreaming sleep, and it can vary. And the difficulty is that as you get older, that amount reduces, and everybody's slightly different, like an individual's their own individual need. But you have a first chunk, which is the longest period, and then you come out of that into dreaming sleep. Okay, and that first stage of dreaming sleep is the shortest. Then after a few moments, 5 minutes, 10 minutes of dreaming sleep, you then go back into either light sleep in stage 2, 3 sleep, 2, 3, and then you go into slow wave sleep again, and you have a shorter period, and so on and so forth, all the way through the night. And by the end of the night, the early morning hours, say 3, 4 o'clock in the morning, you're having hardly any slow wave sleep, or you should be having hardly any slow wave sleep, and you're having large chunks of REM sleep, and then you wake up 5, 6, 7 o'clock in the morning whenever your normal wake time. So in terms of the amount of slow wave sleep, if you plotted the area under the curve effectively of it, you'll see that there's a lot at the beginning, and as you go through the time of the night, it just reduces and reduces and reduces, and eventually 5, 6, 7 o'clock in the morning, you have no slow wave sleep, but you have more REM sleep as you go. So if you plot REM sleep, it goes in the opposite direction. Lots of theories behind that, and this is one of the reasons why they say slow sleep is important, because if it's important, you want to do it first. So that's why there's a predominance for it. It doesn't explain REM sleep in the context that REM sleep is kind of takes its time to present throughout the night effectively. And REM sleep is dreaming sleep. It's a stage of sleep which many people theorize is the preparation for pending wakefulness, is how it's often described. So your brain has to get used to the notion of getting ready, having been asleep for some period of time, getting ready to start again. So the theory is that it's getting ready for pending wakefulness. But again, the theory around why we dream and why we have dreaming sleep as well is simply due to the fact that it's problem resolution and addressing any issues that you might have. Because everybody at home can do this, and you guys too can do this too, is if you have a problem, like we've all done PhDs here, all students here, you know there's been times where you sat there going, my data doesn't make sense. When you wake up the next morning, think about the first thing you think about, and it will not be that problem. Okay. And the theory behind this is a Freudian sort of approach to dreaming sleep. But the belief is that the very short chunk of dreaming sleep is basically where your brain is going, right, so you've now got a problem with your data. Okay. The second chunk is the problem's still there, but how can I fix it? The third chunk is, well, if I did this, hopefully the problem will solve itself, and you will have great data, and it'll be sudden you'll be pushing for like Trump pushing for a Nobel Peace Prize sort of thing. and you like the research is going to be the best research in the world ever. The final chunk is, if I do all of these things, I will have the best study, and I know how to get through this problem. It's going to be the best thing in the world ever. And then you wake up and your brain is in that state where it's now ready to start the next day in a happy mood, because all the big problem from the day before has now been addressed, in theory. Okay, that model also does fit in for things like nightmares as well, in so much as if you go through that process, but rather than finding a solution, you find a further problem, then by the time you get to like the third or fourth cycle, this is now, the world is about to end, my thesis is about to, I've got no reason now to be, I need to get up now to start fixing the problem. And thus you wake up, and that would be considered as a nightmare. Because
so is that why us scientists have more nightmares than the dreams?
Well, things, scientists and students, one thing I would say to all students is that one thing that I definitely found very common, especially in my undergraduate degree, which I didn't realise at the time, I was also starting my master's actually, was a lot of my colleagues were mentioning things like waking up in the morning unable to move, and they thought that was odd. And I was like, well, that's what you're describing there is sleep paralysis.
Yeah.
And I then asked them a couple of questions about it, and they would go, that they had the difficulty breathing, they had a sense of doom and gloom around them. It's very common, actually, a very common disorder. And there's tons of work by Jerome Siegel, who's a legend in this field, whereby they demonstrated quite clearly that this is one of those aberrant events in the brain that is not defined by social cues and social norms. E.g., he went and looked at the presentation of sleep paralysis in nomadic groups that do not engage with Western society, so they can't be open to the cues that we are all being open to, and subsequently found that they present exactly the same. Now, if you've ever seen that picture, there's a picture called The Nightmare. The artist escapes me right now. Oh, I've forgotten his name.
I'm sure if I see it, I'll know I've seen it before.
Yeah, but it's basically a woman who's lying on the bed. It's a very dark image, and she's lying on the bed, her arms over her head, and there's a gargoyle sitting on her chest. And there's like a horse's head in the background, and it looks doom and gloomy. And Henry Fuseli's
Oh yes, I'm looking at it right now. Yeah.
Henry Fuseli's The Nightmare. It is one of those images that is in public literature that everybody sees, and it's quite a dramatic image. But in some ways, it's a very, very good and clear imagery around what sleep paralysis is. It's quite a powerful imagery around it. So it's the sense of doom and gloom. It's basically what happens in sleep paralysis. So your body wakes up without your brain.
So what about, that's really interesting, because what about the opposite? Because I, at least until the age of about mid-20s, was a chronic sleepwalker.
Oh, wow.
So, yeah, I've never said that before. It just occurred to me now. And I've done some crazy stuff. I've walked by the river in my sleep. I have walked on a motorway in my sleep.
Very scary.
Yeah, well, what is that? Do we have any ideas?
Right. Sleepwalking is one of those weird and, I won't say undertreated conditions, but there's a narrative around it, which is that it's... I don't want to say this out loud, because I think many people in the scientific fraternity see it as a problem. Neurologists see it as a problem. Most others don't want to handle it because there's normally something else in the background that can be contributing to that particular problem. The good thing about it is if you're a sleepwalker as a child, you often grow out of it.
Yeah, I don't do it anymore.
Yeah, brilliant. Good news.
I just haven't done it for a while. I might do it again.
All this talk of sleep. So basically it's something which most people grow out of. However, the thing about it, the main trigger for sleepwalking episodes is an unfamiliar environment. Yeah,
because most of the sleepwalking I've ever done is first day of a holiday.
Yeah, first day of a holiday, going to a hotel.
Yeah.
And the thing is, I remember giving a talk to some hoteliers about the sleep vision beds and things like that. It was just an invited talk. It was really lovely. But they commented about the fact that they often saw, and this was like a fraternity-wide thing, literally all of them were saying it, they saw so many people walking through their reception naked, for example, at 3 o'clock in the morning.
This is why I always sleep dressed.
Yeah. Well, some of them probably started
myself in the room if that was the case.
But the thing is, the funny thing is that it does have a funny element to sleepwalking, but there is actually quite a serious side to it, because a lot of people have injured themselves or even lost their lives by acting out behaviours. And basically, it's just the brain's unfettered acting out of a dreamlike state. And it has to be distinguished, because there's sleepwalking, and then there's other things like REM behaviour disorders, which are where there is no stereotypic elements to it. The thing about a sleepwalking episode is that it's normally quite, somebody thinks they're flying, for example, okay, and so they are moving their arms up and down as they walk forward because they're trying to flap their arms. Fortunately, that's fine if you're just doing that in your bedroom or through the reception of a hotel. Whereas if somebody is now engaging with the dream as if it was a real event, and the paralysis is, we have paralysis during sleep, during dreaming sleep, in particular REM sleep, we're cataplectic, we're paralysed effectively from the brain stem itself. When that's not there, that's when you can act out your dreams, and that's what sleepwalking often is. So if you then can engage with the dream, so if somebody is thinking that they're fighting a dragon and that just happens to be their bed partner, that can become quite a serious episode, whereby not only can they do them harm, but they may not know when to stop doing themselves harm. And we've heard lots of quite tragic stories where people have been attacked or mortally injured because their bed
or sexually assaulted. There was those cases where the sexual assaults got overturned in the court because the experts came and gave evidence that actually they're not doing this voluntarily, they're just doing this. Yeah, again, the threshold of arousal becomes a question that I don't think has ever been fully answered. I think in the execution of an assault, because that's if we can talk about it in legal terms, it's tantamount to an assault that's occurred in that scenario, especially things like the sexomnia and so forth. Not sexomnia, that's where you have an excessive sexual drive, but whereby you've actually committed some kind of physical act upon somebody in the commencement of whilst being you commenced an assault whilst in the state of a dream-like state of some kind. I'm not going to make conclusions about the clinical disorder that somebody might have. But the thing is that I've always asked the question, and I've never had an answer to this, is what's the arousal threshold? E.g., if somebody is either being assaulted or assaulting somebody, there's a stimulus. That level of stimulus is quite significant and should be enough to elicit a response from the individual to wake up. If somebody's if I was in a dreamlike state and I'm assaulting somebody, that person may scream, shout, hit back. And all those events should terminate the event quickly if the stimulus is being perceived, and often it does. That's the other thing as well. I'm not saying it doesn't, but sometimes when you hear stories where the event went on for X amount of hours, you sit there thinking, well, I don't think that fits into the paradigm of what sleep is. It becomes something else. Now I'm no legal expert, but I think that with the better understanding, because we still don't fully understand all of these physiological processes that are going on, these clinical syndromes as such, but at the passing of time, some of those decisions that may have been made may be challenged subsequently. I would not be surprised to hear that. So I think we've spoken quite a lot of really interesting sort of sleep-related stuff, but maybe we should take a little step back, because you were describing your coming towards the end of your PhD journey, which went on for a lot longer than you initially imagined.
Too long.
Yeah. So then what happens next? So what did you do after your PhD? And how did you eventually end up here at Hallam?
Okay, right. Well, after my PhD, I graduated in 2012.
How long did it take you? Part-time, obviously.
Right. Well, there was a break-in study for about 2 years whilst I was swapping supervisors. So overall, about 8 years in total.
I mean, for America, that's pretty standard.
Well, University of Surrey and myself, it wasn't. I was not very happy about that. I really wanted it to be. I wanted to move on more quickly. Yeah. But it took me about 8 years in total to finish it. And in that time, I had 2 children and moved house. So, in addition to all the other things that was going on, that whole other job.
92 hours work.
But after I finished my PhD, I should also explain that during my time at the University of Surrey, I helped to set up the sleep service that's still running now, to the best of my knowledge, that was there. And I really became quite focused on the clinical side of sleep.
I was going to ask, when you said the sleep service, do you mean there's like a clinical diagnosis or?
Well, what we realised, myself and the medical director, Professor Nicholson at the time, Professor Nicholson, we kind of came to a conclusion that the University of Surrey is in this kind of catchment area where we had a hospital directly beside us that was able to see patients with respiratory disorders but not treat them and not do the necessary diagnostic investigations. And we had all the equipment and stellar labs. So when we weren't doing studies, we could be that conduit who could provide that service. So we kind of came to the conclusion that we could provide a service And we started off seeing private patients initially, and we did pitch for a couple of clinical service tenders as such. But by the time I left, some GPs were still sending their patients to London, which was like 50, 60 odd miles to Brompton, sending them miles away for a sleep investigation, and for ongoing management of their treatment at that time would mean they'd have to be migrating back and forth over that distance to be treated, and we weren't a fan of that. I wasn't a fan of that. So we set up the sleep service, and I got a real interest in not just respiratory disorders of sleep, but the non-respiratory. So I saw a couple of narcoleptics. I saw one patient who was a fatal familiar insomnia. Subsequently, we didn't diagnose him at the time. We couldn't diagnose him because, unfortunately, this is a disorder that at the time could, and I think currently still, could only be diagnosed at post-mortem. So it was not great, but we made the initial decision that it probably was. This particular patient had been given a diagnosis of another disorder, but had gone back to his GP saying, I'm still not sleeping, and it's affecting his life. So we then got involved and were looking at his history. I sat down with him and realised that in terms of his presentation of insomnia, it had started about 3 years prior to when we had seen him, and it was going in this kind of remitting pattern whereby every 6 to 7 months he was having like a couple of days of insomnia, and then it would go, then it would come back again, then it would go, and then it would come, and it was the periods between were getting shorter. So we did the investigations, we did all the literature searching, and Professor Nicholson and I sat down and went through everything, and it came to the conclusion that it probably was. So because at the time we didn't have a service in the south, the only thing we could do was refer this gentleman to the CJD, acute psychiatric disorder surveillance service up in Scotland, and they took on his care, which was amazing. They just straight away said, yeah, what you've done and presented is enough for us to be interested in this chap. And I remember just as I left the University of Surrey, we actually got a message back saying, yeah, it's confirmed, which we then meant that we knew what had happened to this poor gentleman. But he probably got I think we could say that he got his affairs in order and was aware of what the prognosis was, but it's not a nice disorder to have in any way, shape or form. But by setting up the service, I really got invested into that side of sleep, the clinical side of sleep, more than the academic and research side of sleep. So after I graduated, akin to what I did as an undergraduate, I went into, I had the opportunity to do postdoc. I instead went into clinical sleep. I then spent, 10 years or so working at Aintree University Hospitals, working with patients, working in the sleep laboratory there, involved in a few clinical trials that were going on, not proactively involved in many projects, but the last study that I was involved with at Aintree was the romance study with colleague Victoria Sprung, who great lady. We did the study, she was the coordinator, but I did all the sleep investigation work, looking at how treatments for type 2 diabetes can benefit sleep apnea patients in terms of aiding weight loss. And this is now one of the big areas, a GLP agonists, and how these can actually improve overall outcomes. It's one of the therapeutic interventions that will have a lot of impact going forward, especially given the fact that we have an obesity problem in the UK, across the world, globally, across the world, and we need to have strategies to handle this. Or I think, again, I can take the term for one of my colleagues, former colleagues, Sonia Craig, who said we have a fat tsunami, we're just not doing much to get out of its way. And sleep is one of those disorders, clinical areas, that will be significantly impacted by this obesity issue.
Wow. We could follow the journey. However, you just mentioned sleep apnea, and I remember you kind of specialized in sleep apnea. This is we spoke for the first time. As soon as I heard sleep apnea, I was like, wow, okay, I don't know many people that are specialized in it, if anybody else. So can you just tell us what the sleep apnea is?
Right. Well, sleep apnea is a condition that, and it's one of the few conditions that I can say categorically that everybody on planet Earth can have. Okay, and it's basically a functional collapse of the upper airway, because when we go to sleep, all of our muscles relax, head to toe. Okay, the muscles that line our airways also are subject to a loss of muscular tone. They lose some of their tightness, And what can subsequently happen is if they lose enough of that tone, they can become floppy. And initial floppiness is snoring. So if somebody snores, that's an indication that they have a floppy airway. Okay, so so if anybody out there who has somebody who snores, that's an indication that their airway is already a little bit on the floppy side. If that floppiness continues, it can become so floppy that it can close or partially close. A partial closure is a hypopnea, a complete closure is an apnea, okay? And the number of times that happens repeatedly per hour of sleep, the more fragmented your sleep will be, because I don't think I need to convince anybody of the importance of continuing to breathe at night time. Okay, so if your airway collapses and you pause your breathing, this sets up a whole bundle of physiological processes inside you. The first one is that your body spots that you're not breathing. The peripheral chemoreceptors spot that your carbon dioxide levels, the gas we blow off, is starting to build, and that sends a signal to the brain. The brain kicks in and starts increasing the respiratory drive to get your airway open. So eventually you push through the obstruction after 10 to 15 seconds, maybe a bit longer, and eventually you push the airway open. You normally get a large snort of air, a large inhalation, you do a few rescue breaths, and then your brain goes, job done, you're breathing perfectly now, I'm going back to sleep, and then the cycle repeats over and over and over again. Now the thing about sleep apnea is that everybody does it to a certain degree every single night, okay? And if you have less than 5 apneas per hour sleep, that's considered to be normal. That's not a problem. We wouldn't necessarily treat somebody who had less than 5 events per hour sleep. If you have more than 5 but less than 15, you're in the mild range. And in those situations, if you're tired and sleepy as well, so it is fragmenting your sleep, then it's worthy of treatment normally. If you have more than 15 but less than 30 events per hour sleep, that's in the moderate range, and invariably we treat people who are in the moderate. And anybody above 30 events per hour sleep, which is 1 every 2 minutes of sleep, okay? So 30 events per hour sleep is 1 every 2 minutes. Significant disruption of your sleep, you get treated normally, okay? Just as, again, on the side, a contextual thing, I've seen lots of patients in the moderate and severe range across my career, but the highest I've ever seen was 147 apneas per hour of sleep. And I remember this particular gent, he was a rugby player. Actually, one of the first patients I ever worked with at UCL, and I remember this particular chap. He was a former rugby player, had a massive neck, but a retrographic jaw. His jaw was pushed back, so it was quite a reset. And this was at the time when we had what we call attended sleep studies. So the patient would be sleeping in a bed. We had 2 patients sleeping in different beds, and me, the physiologist, would stay to be the person to respond to what their needs in the night time. Because these are sleep apnea patients, we weren't expecting them to get up much at all, but because of the nature of this disorder, somebody had to be there. And if they were really severe, the idea was in the middle of the night you could put them onto CPAP. Okay, so you get them started on treatment straight away. So anyway, to cut to the chase, this particular chap, I put him to bed. I went to bed in the bunk room, and I think it was about less than an hour later, Stephen, we need you to come out. I was like, okay. Got my stuff on, put my shoes on, went outside, and they said, yeah, this chap, we're concerned about him. And I was like, oh, why? And they just pointed at the screen, and I could see his sats were bumbling along at like 45%. That's bad. So straight away I was like, oh, okay. I went over to him, we woke him up, and he was barely arousable. And I looked at the traces, and I saw that the calculation was suggesting that this was severe. So we had to leave it a little bit longer. So I let him go back to sleep, and I watched his trace, and I watched him. And if he was going that low again, we went in. And eventually, after about an hour and a half, 2 hours of this, I couldn't put up with it anymore. I was nervous. I can't imagine what he was feeling like. So we then straight away, I woke him up, got him aroused and everything else. And I said to him, I'm going to put something on your face. Can you tolerate this? And I put a mask, CPAP mask on him, full face mask. He had a beard, which I couldn't get a good seal. I remember I was struggling with the seal. But he put the CPAP on him, an auto-set CPAP. So this is a machine that measures the amount of obstruction to the airway and responds to it. Okay, so it kind of automatically increases the pressure in response to the level of obstruction, kind of saves me having to titrate things and things like that. So I put the mask on him. It started off at 4. I went the next door, measuring the pressures too, and I saw it go to 4 to 6 to 8 to 10 to 12 to, and it was just going straight up. It was not clearing his airway because he was that obstructed. To cut to the chase, we actually ended up putting him on bi-level ventilation because we couldn't get his airway open. And even after that, he couldn't tolerate the high pressures that it was working at. So I think with this particular gen, again, I left before his treatment pathway was completed, but he had maxillofacial surgery and then went back onto CPAP. So to give you context, because he had a recessed jaw, his jaw was so far back, and he had such a bulky, big, large neck, the two things together was just nightmarish. Right. So he was listed for maxillofacial surgery, where they break the jaw effectively and they advance the lower face forward to increase the luminal space at the back of the throat so that it's less likely to collapse. And they also did a rhinoplasty on him and septoplasty to straighten his nose. Being a rugby player, he'd had some damage to his face as well, so they sorted all of that stuff out. And I think then he had CPAP therapy going forward. But that was the worst case that I've ever seen, and to be honest with you, I never want to see that again. It
sounds really scary.
It sounds terrifying. So I think I've mentioned this to you before in passing, but I've got a family history of sleep apnea. I feel like everything I do has got my family is involved in it. But all of my uncles are on CPAP machines. My dad has been on a CPAP for, I think, almost 10, 15 years, I'm going to say. Obviously, I snore, needless to say. So I'm guessing this is coming in my future.
Yeah.
So my question is, and I'm going to take a bit of a sideways move here, but I recently read somewhere, I can't remember if this was a study or not, so forgive me for that actually there's a correlation between getting certain dental procedures, particularly if you have braces, but braces where you have to realign your jaw, that you are much more likely to develop sleep apnea. Have you come across this by any chance?
Not necessarily dental procedures per se. There are procedures that can be done to improve sleep apnea, but in terms of the scenario you've painted, the thing that jumps out to me is that there is what we call a familial relationship in sleep apnea. Okay, basically, if your parents have underlying sleep apnea, they're quite likely to pass it on to their children. I think it's sex linked, so sex chromosome linked. So it's kind of guaranteed to always be there somewhere. Okay, and that's the work of Susan Redline as well. She's a brilliant researcher who's kind of demonstrated that many years ago, back in the 90s. I think it was kind of confirmed. But the sum total is that if you've got that many members of your family on CPAP, and you are having features of sleep apnea yourself, in terms of things, the thing I would say is that snoring is almost, and I'm going to be very cautious here to say this, but snoring is a little bit like sleep apnea light. Okay, so you have full fat Coke and Coke light. Sleep apnea light is snoring, where the airway is floppy and is collapsible and may well be collapsing, but not to a significant degree yet that it's become a problem. Give it time and it can be. So the thing about sleep apnea that I haven't really touched upon yet is what actually triggers it and causes it. And the thing is, it's weight gain. Okay, so the simplest treatment, and I'm annoyed about this in terms of the clinical perspective and the clinical position that we take in the sleep fraternity, is that we treat the disorder, we don't cure the disorder. And what we should be saying to patients is, I said this in my latter years with my patients, especially the younger patients in particular, is I'm going to give you this machine to treat your sleep apnea. I need you to do something for me, which is to lose weight, okay? Because nearly all of my patients were slightly overweight or had some body habitus issues that they could benefit from by losing some weight. As I said, this is one of the disorders that I know I can give to every single person on planet Earth. And the way to do that is simply put a sufficient amount of weight for that individual on. They'll end up with sleep apnea. You know, it's literally a guarantee. So reverse that process by losing some weight. Now, how much weight is the difficulty? Because again, there's no real predictive element that we can do. We say get your BMI below 25 kilograms per meter squared, and you shouldn't have any sleep disordered breathing. I've seen a lot of patients where the last time they had a BMI of 25 was when they were 12. You know, they ain't going to get there again. And they acknowledge this, we acknowledge this, I acknowledge this. So I don't want them to be disillusioned, because any kind of weight loss will be beneficial, not just for their general health, but for this particular condition. So I always would say to them, have a think about trying to lose some weight, any weight will be beneficial.
Yeah, I think that's a really good thing you said, because I think there are very few conditions that's metabolically related that you will not benefit from losing weight.
Yeah.
But also studies show people do not lose weight. It's almost impossible for you to lose weight. So
I think again, this is like a catch-22 disorder of sleep apnea, because the thing is, when you have sleep apnea, the one thing it does is it makes you tired and makes you lethargic and feel fatigued. So then the minute you have that condition, we say lose weight. So the thing you don't want to do is go on either diet or exercise. Now, exercising when you're fatigued, tired, sleepy, etc., at 3 o'clock in the afternoon, you only want to go back to bed. You're unlikely to want to go and exercise. There's no motivation to kind of push you through. Dieting in its own right, what we do know is that if you sleep apnea is like a sleep deprivation. You're constantly being aroused and awoken. And what we know is that there's 2 hormones, leptin and ghrelin. Leptin being a satiety hormone that makes you feel full. Well, when you're sleep deprived, that's suppressed. And ghrelin is a hormone that tells you need to eat. It kind of makes you prepared to eat some food and get ready to. That's increased when you're sleep deprived. So your body's working against you even for all the ways to treat sleep apnea. So it is like a catch-22 scenario. So to break that cycle is the most important thing. And the only way we break that cycle is through treatment with CPAP. Or NIV or ASV. So you have to break the cycle somehow, and CPAP or the positive pressure machines do that. But then the next bit in that scenario should be now do the diet or the exercise. If you can't exercise because of the other comorbidities, then diet. If you can diet, or you can't diet for some reason, say then do some exercise. And it will be subtle things. I remember lots of my patients where I just literally say, rather than, well, one patient in particular I remember saying, I said to him, when you go to work, drive to work, yes, you need to, because he was a morbidly obese gent. I said, drive to work, that's fine. But rather than parking in the nearest car parking spot, park at the further side away, so you have to walk that distance. And then when you get to the building, take your lift up to your floor, fine. Then once you feel comfortable walking from that furthest part of the car park, walk up a flight of stairs, and then take the lift up. And then when you feel comfortable with that, walk all the way up, and then all the way back down when you go home. And then rather than going to the local shop to get your lunch, walk to the next shop down. And just increase these extra little elements. And I think over an 18-month period, like I say, he was morbidly obese. And we put him onto CPAP as well. But over an 18-month period, I think he lost something in the order of about 6 stone. Kind of subtle changes. He was also dieting as well, but we also broke the cycle by giving him CPAP. And I remember that we repeated his sleep study. It was still positive, but it had gone from being morbidly severe, like 90 events per hour, down to something like 30. And he was aware of he was noticing the benefits. So he was still in the severe range.
So despite having a CPAP, he was still having...
Well, yeah, he was severe.
Yeah,
okay, so I should clarify what I meant by he went from 90 down. He felt a benefit, but we had to objectively prove it. So we took him off his CPAP for a week, repeated his study, and it was still showing. But when we treated him initially, it was like 90 odd events per hour. He'd now come down to 30 events per hour just due to that weight loss. He continued it, and I know that he ended up returning his CPAP machine because he didn't need it because of the weight loss he'd gone through. And I still remember thinking, he still looks chunky. Like he still had weight on him, but it was noticeable he had lost some weight. So the telltale message I would say to anybody who has any kind of suspicions around whether or not they might have sleep disordered breathing is, A, are you tired? Are you feeling genuinely tired during the daytime? Is there evidence of sleep disordered breathing, like witness apnea, so bed partners noticing you stop breathing, or prodigious snoring is being reported? If the answer is yes to either one of those two things, so you're tired during the daytime and you have witnessed the events, the first thing we should all aim to do is try and lose some weight, be active, do something like that. If that doesn't help over, say, a couple of weeks, definitely go and see your GP. And if you feel concerned about the ability to lose weight, go and see your GP as soon as you can and get yourself into the system, get yourself treated.
So are there any other physiological markers that would say, because I have no idea of any sleep disorders I have except from not being able to sleep relatively often. However, whether I have sleep apnea or no, I have no idea. So what would be like a sign, except from, I guess, excessive tiredness?
I would say that even though it's not a physiological marker, and I've got to be clear on my words there, daytime sleepiness is probably the most common one. Okay, the way you should see it is that if you go to bed at night time and you wake up the next day feeling refreshed, you've had a good night's sleep. So in the absence of feeling refreshed, something has happened the night before. Okay, that's and it's a simple 1 + 1 = 2 sort of scenario. The only caveat I would inflate to that would be we do have the midday siesta in some Mediterranean countries, but that is tied in with a secondary hump of melatonin, which is a hormone that our bodies release to help us to fall asleep. And we get a little hump of that around about midday, post-lunch period. It can stretch from midday to about 3 o'clock. Mediterranean countries have a nap, the rest of us don't. So you can feel a little bit sleepier, but you should still be able to function. If you get to that point in the day and you cannot resist sleep, or you are literally dragging the proverbial knuckles on the ground because you no longer can physically move, then that would indicate a problem. So in terms of the physiological symptoms of sleepiness would be one, even though it's not really a physiological symptom, but things like elevated blood pressure and heart rate would be things that would be not easily detectable, but would certainly be something you could pick up upon that would indicate that there's a problem there. Normally your heart rate and would start to gradually increase associated with it. As we had maybe mentioned, increased body mass, putting on the pound sort of thing, would be an indication that you're moving towards there being a problem, and that ties in with metabolic issues. Leptin and ghrelin we mentioned just a moment ago. These hormones would be changed and they would be driving your eating behaviours or your food hunting behaviours around that. So if you're constantly feeling hungry and tired, those two things might be tied in, that your sleep's being disrupted, and that's leading to these other issues tied in with it. Insulin sensitivity is affected by it. You may start to notice some changes in fatigue you're feeling, your blood sugar levels as well, thinking of other things.
That's quite a lot anyway.
Yeah, there's lots of things. Like I say, sleep is a kind of, if you can imagine an orchestra, there's a lot going on.
Yeah.
Okay, and it's difficult to pick one particular element, but there's a lot going on in the background. But all of these things, every aspect of physiology in some way, shape or form can be affected by sleep. When I teach undergrads or A-level students, I often give an analogy of that. Sleep is a bit like a house. Your body is your house, okay? And sleep's part of that. So your skin is the bricks, and the roof could be your hair, and the windows are your eyes and things like that. Your immune system could be the central heating and so forth, okay? And things like that. I kind of say this. The bit you never see on a house is the foundations. But without foundations, the house will fall down. And your sleep is a bit foundational to your physiology. So without it, even if it's like if your foundations are only half the size they need to be, so you're only getting half the amount of sleep, well, a wall or two will fall down. That's what's going to happen. The rest of the house may stay up, but it's going to be wonky when things like this. So it helps to maintain not only your physical being but your mental health, and there's that saying by the late great Bill Dement that if this thing which we call sleep does not have an important evolutionary importance to us, it is the biggest mistake evolution has ever made. Because we're not safe when we sleep, we can be predated upon. It has to be an importance to it, and if there isn't an importance to it, it's a big evolutionary mistake.
And as an immunologist, I mean, I can definitely vouch for that. The immune system functions very poorly when you're not sleeping well. So sleep is absolutely critical. Again,
one thing I always point out to students, but I say this to all the lecturers listening, is that one thing around exam time that's worthwhile keeping an eye on is students and look at their skin. Okay, if you notice their skin is becoming spotty and kind of oily, that's normally an indication that they may be kind of burning the candle at both ends. It's one of the first things that starts to go before the massive sleep impacts and the sleep effects start to kick in. So I'm not saying
fascinating.
I'm not saying that every lecturer should go check out a microscope and check the skin quality of their students, because there's rules and regulations that we shouldn't cross. But it's one of those things that I always point out to students when another team. If you are starting to notice that you're suddenly getting an outbreak of spots, have a look at your sleep. Are you going to bed early? Are you giving yourself enough time? Often it's like you've suddenly taken on a new job and you're working early, first thing, getting up early at 7 o'clock in the morning to an extra shift and all these kind of things. Those are the kind of tiny little impacts over time that start to change. And one of the first things you notice is
the thing that I find fascinating about that is not as a lecturer, but when I was a student, I remember one day going in for one of my final year exams and just looking at everyone and being like, what the hell has happened to everyone's skin? Now that makes sense to me.
But this is also one thing that hopefully you will be able to clarify, because amongst students and also amongst like older people, mature people, people our age, I have a feeling that there is still this like unspoken rule that the biggest hero is the person that sleeps the least and does the most. Can you please tell everybody, because I know it very well, that sleep is important and you are not a hero if you sleep the least and do the most.
And to add on to that, actually, I think this links well back to that thing you were saying about some people, that guy who was only able to sleep for 2 hours. Because we know, like, was it Margaret Thatcher who was like always awake, like never slept? Maybe she was just, her sleep was just done in 2 hours.
Okay, so, just to qualify that a little bit.
Yeah.
There's lots of evidence suggesting that Margaret Thatcher, I think Winston Churchill as well, always noted to have these they worked most of the time, they were sleeping for 4 hours and things like that. There's a lot of pictures and evidence to show that Margaret Thatcher and Winston Churchill often fell asleep in certain situations, such as in debates and things in the House of Commons and so forth. So I would argue that if you are falling asleep spontaneously during the daytime, then yeah, you probably are not, you need more than the 4 hours you are having. Okay, that particular Jen who we saw and had a sleep period of about 1 hour and 47 minutes of consolidated sleep, he was odd because as I mentioned, we did his test during the daytime. We did a whole bunch of blood tests as well to make sure he wasn't like on stimulants and jacked up on stuff to keep him awake and things like that. He wasn't doing that. His blood workup was all fine. There was no elevation in stress hormones and anything like that we saw. And then we did a whole day worth of testing, which is designed to make you fall asleep.
And he still didn't.
And he still didn't fall asleep.
Wow.
So he literally, I told you, I was happy with just shaking your hand for a 10 on him, saying he's going to fall asleep, because what we did in that environment was we took away all what we called the Zeitgebers, the cues that wake you up. We took all of them away, and he didn't sleep. So he had only a sleep need of, from what we can gather, of only about 1 hour and 47 minutes. Now, what I would argue or question, I would love to keep an eye, would have kept in touch with this chap, was that I wonder how he's doing now, because he was quite a young chap back then. We did this, and this was 20 odd years ago. So I'd love to know how he's doing now, and if he's still sleeping to that amount. I think over time you would have to erode that a little bit. I can't see how physically 2 hours sleep out of 24 a day is maintainable long term. Everybody else on planet Earth is operating at 7.2 to 7.5 hours out of 24, roughly round up to 8. So I can't see that that's sustainable, and there's a lot of evidence to show that patients who have such short sleep periods either end up with some mental health issues or some long-term physiological problems further upstream. So I kind of wish I'd kept in touch with him. I don't know if I could ever find him again, sort of thing, but he was one of those people that I kind of sat there thinking, yeah, I don't understand what's going on with you, and I don't have an answer. I just have to accept that objectively right now, looking at the information we have in front of us, and you as a patient right now in front of me, you don't fit the norm. You're the outlier from our clinical understanding.
So don't be a hero is what we learned from there.
But to answer your question, the importance of sleep, as I mentioned before, it's foundational. It's the kind of thing that holds the physiology up. And again, I mentioned that I can make anybody have a sleep disorder breathing by putting enough weight on them and by fragmenting their sleep. I can also do the same. I can unleash people's. I'm not that I'm going to do this. I should point this out. I suddenly realised, like, I'm going to make everybody.
Stephen's superpower.
But no, I can unleash mental health disorders in people by simply removing their sleep. There was also a very highly unethical study that was done many, many moons ago, 60s and 70s, where they removed specifically the REM sleep from a bunch of medical students, and they all became narcoleptics, whereby they suddenly spontaneously fall. It resolved itself, don't worry. It resolved itself, but they became narcoleptics after, I think they did about a week's worth of REM sleep removal. So they recorded their sleep, and when they went into REM sleep, they woke them up. And then when they went back to sleep again,
I hope they paid them well.
Medical students. I'm sorry, probably not. So they all became narcoleptics. What we also saw in that was, again, the importance of sleep was that if I'm remembering it correctly, these individuals slept for about 18, 19 hours for about 2-3 days, and then were back to normal. Okay, so during the day they were in narcolepsy, but then after they recovered their sleep, they started to appear normal again. But the final thing to kind of talk about the importance of sleep is that we know it's vitally important, in so much as, again, when I teach my students, my undergrads or my A-level students, I talk to them about sleep. I give them a couple of things. I say air, water, sleep, sex and food. Put them in order of importance, okay? And of course all the boys go sex first, and I just say stop, think about it seriously. And they normally get air right, they normally get water right, and they say that those two are the most important. Then they say it's food, then they say sex, and they say sleep. I say no. Sleep's the third important one. Okay, so it's air, water, sleep, food, sex. Sex is optional, basically. You don't have to procreate. And what we kind of know is that if you are awake for anything more than about 21 days, it's not survivable. Okay, e.g. you would pass away. Normally, actually, I say 21 days. I don't think it's difficult to get to the 16 to 20 odd days. You would be struggling at that kind of point. And
without any sleep.
Yeah. How do we know this? Well, unfortunately, this was the work of the Nazis, basically. Just Goebbels and these people kind of gave us information because nobody would want to do that research per se. And there's some studies which have been done in Drosophila flies, fruit flies.
I was going to ask about animal models.
That kind of show that kind of relationship. But what we do know is that in the complete absence of sleep, e.g., the minute somebody tries to entertain the notion of going to sleep or falls asleep, you stimulate them and wake them up and arouse them so they can't sleep. Within 20 days, 21 days, it's fatal.
That's horrifying.
So lack of sleep also just contributes to mortality. So the people that sleep less, obviously knowing the physiology, what happens during the sleep, we can probably say that they live shorter.
Yeah. The thing is, going back to that Bill Dement statement, if we don't need to sleep, then this is an evolutionary mistake. Sleep thing, but we know we do. So it has an importance, and that is the long-term goal of any kind of sleep person, is to identify what that is, why we sleep. We don't know. There's lots of theories around why we sleep, and none of them hold true. There's always like a gap. Like, for example, there's the consolidation theory and memory consolidation, the adaptive theory. As consolidation is about energy conservation as well. But like in terms of the energy, in terms of calories that we save by sleeping as opposed to lying perfectly still, it's only about 180 as a Mars bar. From an evolution perspective, it's not worth the effort. So there's more things going on in sleep that the body has evolved to accommodate that happen during sleep that are more functional and vital to our existence, and without them we don't survive.
I want to again go back to the career journey, because and it's great that we've kind of taken pauses to sort of go
your journey is so interesting that we could talk about every step and research you did for like 2 hours.
It's great for podcasting. It's amazing. We've heard a lot of stuff. Then so you went away, you worked, set up the center for 10 years. And then what happens next? So how did you end up in Hallam?
Right, well, like I say, when I was at university, I set up a sleep service there, loved working with patients. It was actually making me happy. There was a happiness associated with kind of helping patients. And one of my friends, their father was ill. We didn't know what he had. He was just very tired during the daytime, so we did a sleep study. If only had sleep apnea, we got him treated. And it's still one of the things that makes me really happy that I was able to help out in that way. However, when I finished my PhD, I decided that I really wanted to focus on the clinical side of my expertise. So I took a job at Aintree University Hospitals, where I worked for, it would have been almost 10 years actually before I left. So I worked there, like I say, got involved in some clinical trials, but was predominantly working with patients with sleep disordered breathing, working with John O'Reilly, who's, if anybody knows anybody in sleep, John O'Reilly is one of the real top names of sleep, eminent scientist in the British Sleep Society, for example, but across the globe. He's a really top doctor, really top person. I got to work with him for a long time and really got to learn a lot from him. Helped out with the narcolepsy clinics and, like I say, set up various protocols that I assume still might be being used, a thing which I call the excessive daytime sleepiness protocol, because we did have a cluster of patients who kind of fell into this horrible hinterland whereby they had significant problems with their sleep but were testifying that they were not sleepy. Okay, and these were things, people like professional drivers and pilots. Okay, so we needed a portfolio of tests to be able to accurately monitor and measure these individuals and be able to be saying that yes, you may have significant sleep disorder breathing, but we can see no tiredness, because there's sleep apnea and sleep apnea syndrome. It's very, very boring to tell the difference, but basically one has tiredness, the other doesn't. So you have collapse of your airway and you're not tired, and syndrome, sleep apnea syndrome, is where you are tired effectively because of the nature of disordered breathing. So we had to have tools to monitor, to measure these individuals. So subsequently I did that for 10 years. Then I left and went to York teaching hospitals to run the sleep service over there. I started working there on the 5th of February 2020, and straight away everybody will go, oh, okay, because within less than 6 weeks my little boy had the flu. I had the flu, which I'm pretty sure was COVID, because one of the things was that COVID was first detected in York. I remember I gave a lecture to nurses in that first week, the second week that I was there, and then 2 weeks later I was like and struggling, and it was not very great. And then by March I was in lockdown, and so because I had asthma, because of my underlying asthma, I was
you were protected.
So I had to work from home for however long. The kids as well were at home too, so I worked at York, and after 4 years, lots of stress, lots of not a nice working environment, I'll just say, I decided that I needed a change, amongst other things. So I then spotted the job at SHU, and I just wondered whether the switch to academia would be something that I'd be interested in. Had a chat with the wife, because I knew that the distance of travel, because I still live in York, and it still have a long way to travel each day. I decided it was worth the spin, so I decided to apply for the job. Actually, I applied for the job at Sheffield Hallam, and I also applied for a job at Leeds, University of Leeds. Leeds never got back to me, so if anybody from Leeds is listening, but SHU did. And I remember having my interview and this is how funny it was. I had my interview and I planned my route, so I was driving in, there was a crash on the M1, I got stuck in traffic, I had to phone to the department and pleaded with them like, I'm going to be there, I'm just stuck in traffic, my Google Maps says I will be there 5 minutes before the appointment, I'll park up and I'll run straight over. 10 minutes late, pulled into the car park, I ran all the way here, went upstairs, got into the meeting, I literally walked in, they were like, oh, well, you're next to give your presentation, because I had to give the presentation. I gave my presentation, I whizzed through it. I remember I was asking very tricky questions because I talked on actigraphy. I was asking really tricky questions. I thought, oh my God, I think I've stumbled all the way through that. I didn't know if I gave the right answer there. I then had an interview. My brain was a bit scrambled. I don't know if I answered any of the questions. And then at the end of the interview, I remember leaving and my shoe fell apart. I just thought, this is the Lord's telling me something, that I'm not going to get this job. That couldn't have got any worse, because everything was going wrong. I remember I walked very slowly all the way into town to the shoe zone and had to buy a new pair of shoes before I went home, because I couldn't hold them together. So I generally thought that I wasn't going to get it. But when I had a chat with the interview panel afterwards, they basically pointed out that all the elements were there, that I'd done all the right things, I had been quite confident and open with all the questions, and I'd answered them better than I thought I had. And I think it's just because it had been such a stressful day up until that point, I think my brain had convinced me that I hadn't got the job. But I've been here now for nearly 19 months now, and even though it's been a tricky switch between clinical and academia, it still utilises the good skill sets that I've amassed over time. Because the one thing I I kind of enjoy doing is talking to students and being kind of prescient for them, and that's how I treated my patients. Really, I was always kind of thereabouts for them. You can contact me whenever you need to, sort of thing. That doesn't always work when you've got 170 students on a course that really want to talk to you about sleep, but it's that side of my personality kind of it fits this environment. It also gives me the opportunity to kind of answer some of those questions and research questions that I still want to have answered. So yeah, it's been brilliant for me, and I've loved every minute being here.
I think we should do a Q&A with Stephen. Like, your students will submit the questions and we will answer.
That's a fantastic idea. Stephen's up for that.
Wow. What is your sleeping routine? Because obviously you're a sleep scientist.
That's a good one.
And maybe you are the shining example for you students. However, I know that very often is the other way around.
I can see Stephen shaking his head right now.
So tell us the difference between the perfect Stephen's routine, sleeping routine, versus the reality.
Well, the thing is, again, everybody's sleep need is individual to them. So I think it's difficult to say there's a right or wrong way to sleep and that kind of stuff. I'm not one of those kind of do it this way or else, okay, because everybody's slightly different. And as I mentioned, I see a chap who slept for an hour and 47. I still don't understand. So everybody's going to be individual. But in terms of my sleep, I think for the first 34 and a half years of my life, my sleep was pretty good. I exercised and I kept my weight down, and I was kind of stimulating myself in the during the daytime. So when I went to bed at night time, my brain was like, wow, good time to rest. Because all the memories and things like that were being consolidated and so forth. And I slept perfectly well. I'd go to bed at 10:30, 11 o'clock at night. I'd wake up at 7, 8 o'clock in the morning. I would feel refreshed and I'd be great. And the reason why I emphasise it was 34 years and 6 months or so, that in the 7th month I had my first child and sleep started to change. I couldn't get to the gym as much. I started to put on a few pounds. I didn't sleep became optional. Is the best way to describe it, because I was still trying to do my job and everything else. And when you got, and I think I say this to all fathers out there, is that I could not allow my wife to have to also get up at the night time, having gone through 9 months of the stresses. I had to do my bit, really. Granted, my wife being so great, she still got up and did her bit to look after the children, but I tried to do my bit as much as I could, and that meant that neither of us got any sleep for the first 2 years. And also we moved away from our family down south, we moved up north, we moved into a little village. We had a good circle of friends around us, but no family members who we could say, Grandma, just take them for 2 days, sort of thing. We couldn't do that, so we didn't have that luxury, so it was just us. But my sleep has changed, and I think that as I've got older, I'm more aware of the fact that I don't get as much sleep as I probably would like. I think working at SHU as well, because I'm travelling so much during the daytime, I end up getting home and I still got a few things I need to do, so I end up creeping into the latter hours of my day, so my brain isn't completely wound down by the time I'm ready for bed. So all these things start to come into play. I have a TV in my bedroom, and if you follow sleep health advice, you shouldn't have that. So I'm a sinner. Okay, I don't follow exactly what I should do, but I think that I try to, and what I do is I listen to what my sleep needs are. Let's put it like this: if I wake up on a weekend and I wake up and I stare at the ceiling and go, I need another 3 hours, that tells me straight away that I have something's gone wrong with my sleep at night time, and I start to think about what I can do to address it. And I look at all the obvious things first. I have got to the point where I've done sleep studies on myself to find out if my sleep okay.
Not ethically recommended.
Yeah, not everybody can do that, but I just do oximetry. But things like most people have a smartwatch. I now always wear my smartwatch, even though it doesn't tell me a lot of information about my sleep, not to the level that I would really want it to be. It's better than nothing. So it gives me an indication what my heart rate is like. It gives me an indication of what my BP is, and it gives me some basic information about my sleep stages. So it's a useful tool to say, yeah, this is okay, or the other thing it tells me is that it gives me a sleep score, and when I drill down into the numbers, there's one particular element about your oxygen tension across the night. So it tells you if you've actually got more likely to have sleep apnea. And I keep watching that one in particular because it's my personal interest. And that's a useful tool to have. It just gives you an indication of what might
I think that's a whole different podcast into like the
Yeah.
technology we can all use
Yeah.
for sleep. Right, thank you very much, Stephen and Marta.
Thank you so
This
much.
was amazing. The whole thing was, I think, will be really inspirational. Both your journey, because it shows the depth of the clinic and academia, and if you've married that with family and all the challenges of life, I think this will be really inspirational, particularly for students. I think,
Oh, yes.
but also for us. I think we've learned
Very.
a lot, and the science was just
Wonderful.
mind-blowing.
It's just such a never-ending topic. We could ask so many questions, so many more questions. You saw the list. There's just so many of them. But yeah, maybe next time you'll come to our podcast as well, and we will just have a very specific, either because we didn't talk about exercises and sleep.
Yes, that's
Technology as well. We wanted
Yes.
to talk about that. That never came up.
Yeah, but
next time.
there's only so much time. So thank you so much. It was wonderful.
Thank you.
Thank you.
Till the next time.